Hello and welcome to this month's ERJ podcast. My name is James Chalmers. I'm the chief editor of the European Respiratory Journal. And every month at the journal, we bring you a highlight from published papers in the journal this month. And we're going to be focusing on lung function for April. So we've got a little Easter egg, a little present for you to talk about the controversies in how we define airflow obstruction in people with lung disease. The publication this month is a joint statement by Glee and Gold on the definition of airflow obstruction in lung disease, and I'm delighted that we've got one of the lead authors with us to discuss the paper in detail, and I'll let her introduce herself now.
Hi everyone, my name's Sonia Stanojevic. I'm a respiratory epidemiologist based out of Dalhousie University in Canada. For about 10 years, I was the chair of the Global Lung Function Initiative, GLI or GLI, and I'm delighted to share our breakthrough in the discussions and joint position that we had with the GOLD Scientific Committee.
Thank you so much, Sanya. So this paper addresses an ongoing controversy of how to define airflow obstruction. My understanding is GOLD throughout their history has advocated for the fixed ratio, FEV1 over FVC less than 0.7, whereas GLI's base this on the lower limit of normal within a healthy population. So give us a bit of background to how that divergence happened and what the implications of that are.
Yeah, and I think it's an important point to make, like it wasn't necessarily a divergence, but that these two groups came at this solving different problems for different purposes right from the outset. So when the GOLD Committee was established, when we started recognizing COPD as a major burden, they looked at data the same way that Global Lung Function Initiative has looked at otherwise healthy individuals and found that the lower limit of normal, or the point at which we differentiate between health and people with COPD, was 0.7 of that ratio. In another world, in a parallel world, the ATS and ERS pulmonary function testing working group, which was looking to standardize how we measure and interpret pulmonary function tests, was advocating for the lower limit of normal, or looking at how that ratio in the FEV1 FVC changes based on your height, your age, differences between males and females. And they've been promoting the fifth centile, or the lower limit of normal, since around the 1990s. So both groups kind of came up with this approach very early on and then stuck to it. And right from the very beginning, there were open letters and controversies, as you say, advocating that one is better than the other. I'm sure that all of our listeners have seen in the ERJ and every other respiratory journal comparisons of these two cut points and in which populations one does better than another. So generally, it's thought that the fixed ratio misses early lung disease. So in younger individuals, we're perhaps underdiagnosing, whereas in older individuals, the fixed ratio ignores the age-related decline. Lungs get wrinkly as we do, and that we may be overdiagnosing in older individuals. So that's the starting point in the debate, so to speak.
Yeah, I love the idea of parallel worlds and the sort of multiverse of lung function communities. So the statement tries to address some of this difference that's arisen. What does the statement say, and what are the recommendations in terms of how we move forward from here?
A couple of years ago, I was invited to join a working group of the GOLD COPD committee, and we started having this conversation. Where do these differences arise from? Why do they arise? And in having open and transparent conversations about this issue, we actually realized that we agree on 99.9% of the issues. In discussing this, we came to consensus that COPD is a tremendous burden in the world. We have, at least we know, about 400 million people living with COPD, and the vast majority of symptomatic people are actually underdiagnosed. And so what we thought was to put down our differences, put up the white flags, and really think more objectively about how do we move forward? What are the key issues related to the diagnosis of COPD? How can we learn from each other and bring forward the science to really address the core issue? And so the recommendations that we came up with was first, the absolute number of people that are diagnosed differently or differentially between these two thresholds is really small. So the vast majority of people with clinical indications of COPD and measures of lung function will meet both criteria. And that's really the majority of people that we typically see. Similarly, there's a large group of individuals across all ages that are going to be normal by both criteria. The consensus that we reached was that there is validity in both approaches. Neither is right or wrong. And in different clinical contexts, both may provide very useful information. So we were adamant that we shouldn't be overdiagnosing COPD. That is not the intent of either definition or either group. And because there's been this controversy, because there's been adamancy that there's one that's right or wrong, and that's how all the papers have approached this, we really wanted to remove that from the table. Our goal is to identify airflow obstruction, to identify COPD in as many people as we can. We have the tools to do so, and we're not using them. So our second major point of agreement is that the FEV1 FVC ratio, our hallmark measure of airflow obstruction, should be used to confirm the diagnosis of COPD. So we shouldn't have individuals who have a diagnosis without an objective measure, and spirometry and the ratio is our gold standard. We also know that spirometry alone is insufficient to make that clinical diagnosis. So we need the community to really look at the patient more holistically, looking at their exposures, their medical history and symptoms, and then using spirometry and the ratio as a complement to that clinical decision-making. We now better recognize that COPD is caused by many other exposures, not just cigarette tobacco exposure. And we need to look at patients that might have risk factors for airflow obstruction and chronic obstructive pulmonary disease that aren't our classic hallmarks. And generally, we see lots of inequities in people who are misdiagnosed with different criteria. Typically, women are less likely to be diagnosed with COPD if you use the fixed ratio relative to the lower limit of normal. People who have prematurity associated lung disease, so children born prematurely who are now for the first time reaching adulthood, we see that they have hallmark symptoms of airflow obstruction that are often missed using some of our existing tools. We also recognize that we are completely underusing spirometry globally. So spirometry has a perception that it's a very challenging test to do, but in reality, it's simple, it's inexpensive, and just like in cardiology, everybody has their blood pressure taken, everyone should have a measure of lung function or spirometry taken. GOLD and Global Lung Function Initiative completely agree that we need good quality maneuvers. Spirometry is an effort-dependent test, and if we don't take that effort into account, we're just causing more noise to an already problematic field. And so we want good quality tests, but I think with the technological advances in spirometry devices and software, I think we can have a little bit more flexibility to do this test in the communities that we need to do it in, and do it in ways that align with the resources and opportunities that exist in places around the world. The differences are small, and truthfully, when the test quality is poor, then the differences between the two thresholds are moot. So we really need to focus on getting spirometry into more hands to be able to get those objective measures of airflow obstruction to support the disease. Another controversy that your listeners may be aware of is how we define severity. So GOLD uses percent predicted. ATS, ERS, and Global Lung Function Initiative use C-scores or standardized residuals of that just healthy distribution. The reality is neither of those are perfect. If we're thinking about disease severity, we need to think about how patients feel, function, and survive, and a number isn't necessarily going to solve that problem. And so both groups agree that we should be moving away from race-specific approaches where we might be misclassifying people who come from more marginalized communities. But in reality, what we are advocating for is a new way of classifying severity that really reflects the patients and not these arbitrary thresholds, whether they be statistical or historical. Those were the main things that we debated, discussed, and agreed on.
Fantastic. So many important clinical messages there. I really like the message about severity. I've always thought it's strange that we define such a complex disease by a single number. So you have a patient with multiple exacerbations, terrible symptoms, but they're mild COPD because their FEV1 is 81% predicted. It makes no sense. And so good to see GLE and GOLD knock that on the head. Some also really important messages there around access to spirometry. But coming back to this key clinical point, as most of our listeners will be clinicians, if you're seeing a patient tomorrow who's a smoker, who has symptoms, you suspect COPD, their FV1 over FVC ratio is 71% on the spirometry, but the lower limit of normal suggests obstruction. How do we deal with that patient?
That is an excellent question. That is what we spent many hours discussing and debating. And the reality is, whether you're using the fixed ratio or the lower limit of normal, measures of airflow obstruction, that FEV1 FVC ratio, is a continuum. There's no cliff that a patient jumps off of just because they happen to fall on one side or the other. And in reality, there's a fuzzy zone, a zone of uncertainty around both of these limits. And if we look at our large population-based studies, the confidence intervals or the zones of uncertainty around both these limits overlap tremendously. And so what I would caution for individuals that are in that uncertain zone where they might meet one criteria and not the other, whichever one of the two criteria it might be, I think clinicians went to school for a really long time to deal with these complex cases. And what we want people to be thinking about is the possible risk factors that an individual has. In the case that you explained, where it's a symptomatic smoker who's sitting on that borderline, that's very much likely COPD person who's likely to respond to therapy. If someone walks in who is completely asymptomatic, who has no significant history and is sitting on that border, we shouldn't be rushing to label that individual as COPD. That's somebody that we might bring in for additional testing. That's someone that we might bring in for chest imaging or a more sensitive test if we suspect that there's lung disease. We're advocating for more spirometry, but spirometry is not perfect. We know that there are many people that have subclinical lung disease, whether it be mucus plugging or bronchiectasis, emphysema, that we can see on CT, and their spirometry comes out normal no matter how you look at it. Those are the individuals, particularly ones with a significant risk factor history or symptoms, that we want to follow. Symptoms are not normal. And no matter what criteria we're using, it's really important that we follow through and ensure that individuals receive a timely diagnosis and timely treatment. Oftentimes, by the time we're diagnosing COPD, it's too late. And even some of our new therapies that are available aren't going to reverse that permanent disease that's already been established. And so by testing more people, getting more objective measures, and getting the correct diagnosis for the correct person, I think all of our listeners have the skills and the knowledge and the capacity to deal with that uncertainty around the borderlines of the two criteria.
Yeah, I think that beautifully aligns with where I see the field of COPD is going in a lot of the papers that we get at the ERJ now, which is around trying to identify the disease earlier. So taking into account not just spirometry, but also is there emphysema on CT scan? Is there mucus plugging? What are the symptoms like? What are their exposures? Other measures of lung function beyond spirometry in difficult cases, because we treat COPD too late, which you really emphasized very nicely there. My personal opinion, I think this is taking us in the right direction. And I think it's really nice for our listeners there to emphasize the primacy of a good clinical history and our clinical judgment and using the tests in association with that. So Sanya, thank you so much for joining us. We really appreciate Glee and Gold choosing to publish this in the ERJ and really appreciate you joining us for this discussion. Please join us next month for more exciting studies from the ERJ. My name's James Chalmers. Thanks so much for being part of the April podcast.